once diagnosis occurs, the next step is to employ risk-based treatment strategies. That's the standard of care now. My initial play when I'm not sure what's going on is usually to diurese the patient. I always tell my fellows, if in doubt, start with diuresis. We've built actually a multidisciplinary team in our institute to try to think about pulmonary hypertension beyond just the vascular disease that it is.
Hello and welcome to part 3 of this deep dive series with me, your host, Dr. Saranya Ravindran. Let's dive in. So we've talked a lot about detection and diagnosis. I'd love to hear more about management of PAH. So once you've made that diagnosis, what does best practice management look like?
Great question. And let me just emphasize that best practice management starts before the diagnosis. I mentioned before, but I just want to emphasize again, confirming the diagnosis, and this is not Neal Chaisson speaking. This is uniformly guideline driven, that confirming a diagnosis in an expert center is essential because of the high prevalence of re-diagnosis or changing diagnosis in patients who have been diagnosed outside of an expert center. But once diagnosis occurs, the next step is to employ risk-based treatment strategies. That's the standard of care now. And doing that using dual oral therapy in most patients, and then escalating therapy quickly in patients who continue to have features that are either considered high or intermediate risk of disease progression. Really anything over a 5% chance of disease progression within 1 year. Now, follow-up of these patients includes a very frequent multimodal approach, which includes assessment of hemodynamics, functional class, symptoms, patient biomarker profiles, and we use that to draw a picture of their risk of disease progression. What I think is missing in these patients in many practices is the intensity of how aggressive we are at employing this multimodal approach to try to get these patients from intermediate or high risk of disease progression rapidly down to a lower risk. And what we know is if we don't do it early, the chances of getting them to a low risk of disease progression is very small.
So if a patient with known PAH presents, a patient with known PAH presents acutely with worsening hypoxia, how should frontline clinicians assess and stabilize those patients?
Well, first of all, patients with pulmonary arterial hypertension present with other things as well. And it's really important not to anchor yourself on the pulmonary arterial hypertension. So patients with PAH get pulmonary emboli, they get pneumonia, they develop arrhythmias, they also develop right ventricular failure. And so maintaining a broad differential diagnosis of the reason for the worsening hypoxia is important. Now, in patients who have worsening hypoxia, and you've ruled out a pulmonary embolism, or a pneumonia, arrhythmia, or left heart failure as a cause of their worsening hypoxia, the other thing to think about is a new right to left shunt. And commonly, as patients develop acute on chronic exacerbations of the pulmonary hypertension for one reason or another, they're at risk for developing these shunts, often through a new patent foramen ovale. And so in those patients, you may want to get an echocardiogram with a bubble study to assess whether or not this shunt exists. The problem is once those patients have developed the PFO, the solution is not as simple as just closing it, because that PFO has been created or exists now as essentially a pressure pop-off valve. And so the conundrum becomes, how do you treat that patient who has a new PFO? And that gets a little bit vexing, and really focuses on improving RV function, but just as important, and maybe more important, dropping the right ventricular or the pulmonary artery pressure through aggressive therapy. My initial play when I'm not sure what's going on is usually to diurese the patient. I always tell my fellows, if in doubt, start with diuresis. You'll be right 99 times out of 100. But if you're not in that situation and you're not a pH center of excellence, the next step beyond that is contacting a pH center or the patient's pulmonary hypertension provider urgently.
And are your hypoxia guidelines in terms of target oxygen saturations different in these patients?
Yeah, that's a great. Uh, so there are many guidelines that suggest keeping the saturation greater than 90% or 92%. To
Hmm.
my knowledge, and I may be wrong, but I'm not aware of any studies which have definitively established a guideline at which, um, a lower oxygen would be detrimental. I think a lot of this is based on what I like to affectionately call expert opinion, right? Where the physiology of hypoxia promotes vasoconstriction in the pulmonary arteries. And so if you have a patient who's hypoxic and then you drop their saturation to 87, 88%, it's plausible that you may be contributing to additional hypoxic
Yeah.
vasoconstriction. And so the targets are often set a little bit higher to try to avoid that. But I don't know that that is data driven. I think it's just physiology and expert opinion driven.
Yeah. So, how is decompensated pH managed in the intensive care unit? And what role do vasopressors, volume control, the inhaled vasodilators play?
This is a complex uh, question. And the reason it's complex is we really have no idea how to manage decompensated pulmonary arterial hypertension in the ICU. There are general principles, but but in fact, actually, it's a little bit frustrating that in 2025, most of our data is either anecdotal data or limited to small animal models or models that are extrapolated from other diseases. That being said, I think there's a couple of general principles that are probably helpful for the clinician who develops the patient with decompensated right ventricular failure in the setting of underlying pulmonary hypertension. The first is diuresis, as I said before, is usually a good idea. Okay, it's very rare that patients come in without a very good explanation. Otherwise, it's almost never occurs that patients come in volume deplete. Um, the second is when using vasopressors, we tend to start with norepinephrine.
Hmm.
We will often use vasopressin. The reason for both of those is there is some data that suggests that both of those have vasodilatory properties in the pulmonary circulation. The, the pressor that you want to avoid is alpha 1s. And the reason is things like phenylephrine actually have fairly significant vasoconstrictive properties in the pulmonary circulation. And so you actually can work against what you're trying to achieve. And then the third uh, principle is that when patients are hypotensive, there's this inclination to want to stop their pulmonary hypertension meds to prevent them from being hypotensive. But it's important to remember that if you stop the pulmonary hypertension meds, you're potentially increasing the right ventricular afterload. And so now you have a patient in right ventricular failure where you've just made it more difficult for them to pump blood through the pulmonary circulation because those vasodilators are gone. And so we continue their pulmonary hypertension meds and we augment their blood pressure with things like norepinephrine or vasopressin when necessary. In patients who are intubated, you can use other medicines like inhaled nitric oxide, inhaled epoprostenol. Those
Mm.
things can reduce RV afterload and tend to have a pretty durable effect. Um, what I would say is avoiding intubation unless absolutely necessary is also a good principle because um, intubation can worsen hemodynamics related
Yeah.
to the physiology of uh, venous return and RV afterload, and so we try to avoid those at all costs.
So, you mentioned some of those in-hospital medications, and the other things you've mentioned is diuretics. Now, I'd like to know what are the at-home treatments that are involved in that, pH cocktail?
So if we had this discussion a year ago, I would have told you that there's three main pathways. One of the exciting things about pulmonary hypertension in the last couple of years is that there's been a whole slew of trials going on to look at brand new pathways, not sort of me too drugs in the established pathways. The three sort of workhorse pathways include the endothelin receptor antagonists. Um, those are things like bosentan, ambrisentan, macitentan are the three that really exist on that pathway. Phosphodiesterase inhibitors or soluble guanylyl cyclase inhibitors. Those are things like sildenafil, tadalafil, or the SGC stimulator riociguat, all work in that pathway. And then finally, prostacyclin analogs like epoprostenol or treprostinil. Um, and those three pathways really work towards uh, reversing or halting aberrant vasoconstriction at the level of the pulmonary artery. They don't actually significantly affect disease progression. Now, more recently, there is a new target, which is called an activin ligand binding medication. That drug is called sotatercept. It was released in the United States in May or April, I think, of 2024. And that has really upset or changed a lot of people's paradigm of how they think about, how they use these drugs. There's some guidance in the current guidelines of how to potentially think about sotatercept, but I would argue that the jury is still out of how to incorporate this medication into patients, just because it's so new and we're not quite sure how to use it. What I can say is that sotatercept works upstream from the vasculature, and so it has in trials been very positive in changing the pulmonary vascular resistance and many other markers that we consider associated with disease progression.
And aside from medications, what are the other complementary treatments that would, involve having a multidisciplinary team approach?
Thanks for mentioning a multidisciplinary team. I'm a pulmonologist by training, and I'm simply one part of the puzzle. And I mean that in earnest. So our group fortunately has cardiologists and pulmonologists that has worked in a lovely way, because I can call on cardiologists to help manage some of the cardiac specific things like arrhythmias, um, concomitant left heart failure, etc. But there's more than just physicians in this team. We rely heavily on our pharmacists. We rely on nurse practitioners, PAs, clinical nurse specialists, rheumatologists, dietitians, psychiatry and psychology, and then palliative care. We've built actually a multidisciplinary team in our institute to try to think about pulmonary hypertension beyond just the vascular disease that it is. There's comorbidities that I mentioned before, like connective tissue disease or liver dysfunction from static elevated right atrial pressure, and tons of psychosocial stress. And all of those things impact the outcomes and require a coordinated approach. And so to the person who's listening and thinking about how can I optimize my center or my practice, the most important part of this in some ways is to not go it alone, but to make sure that you have a committed team for seeing these patients and understanding the things that affect these patients on a day-to-day basis.
Yeah, absolutely. And that, I guess, goes for every condition, not just this one.
Yes.
But especially for PAH, which from what you described is extremely complex.
Yes.
So you mentioned briefly about some gene-targeted therapies, and I imagine this is part of those new or investigational therapies that are on the horizon. Can you tell us a bit more about that and any others that may be coming?
Sure. So probably the two pathways which are most prevalent in sort of in furthest along in studies have been uh, one, there's a tyrosine kinase inhibitor pathway that is being looked at, and then additional therapies targeting BMPR and the TGF beta signaling pathways, which are aiming to essentially enhance sotatercept, but with fewer of the potential side effects or downstream side effects. There's also drug trials going on to look at inhaled and oral prostacyclins that have either better tolerability or better administration profiles. And I think that those are all pretty exciting things because whether that is improved patient tolerability of a drug that we already have, but we're limited in our use by the ability to apply it to a patient who might otherwise be working or have an active lifestyle. Um, there's whole different signaling pathways that we're starting to look at, and I think that as these things start to move through the discovery process, it is going to continue to launch other ideas and and improve our ability to offer precision medicine to these patients in ways that we haven't been able to do before.
And finally, why should PAH stay on the radar, even for general clinicians who may only see it occasionally?
This question goes back to a little broader question of what are we doing as physicians? And maybe I'm in that space because today's the first day that we had to interact, or we got to interact with our new critical care and pulmonary critical care fellows who are just matriculating. And so just before this podcast, I had the opportunity to go speak to them and
Yeah.
introduce them to our hospital. And one of the things that I said to them is, what what are you doing here, right? Why are you in this training program? All of you could have gone and been physicians and probably pretty successful. But the reality is that as physicians, as caregivers, we're in the business of changing lives. And with respect to pulmonary hypertension, changing lives equates to figuring out how to be discerning and detecting patients early. Every
Mm.
breathless patient doesn't have asthma or obesity or anxiety. And if we catch pulmonary arterial hypertension early, we can preserve the life that that patient has, not only
Yeah.
just their right heart function or their 6 minute walk distance, but what we give patients is that quality of life, the years or decades to be with family, to work and feel like they are gainful, to be satisfied with their health. And in my opinion, it goes much bigger than um, some physiologic or some medication state. It goes back to what would you want for your mother or your loved one or your child? And really that is somebody who doesn't give up on thinking and doesn't just sort of take the shortcut route. And that's why pulmonary arterial hypertension needs to be on the radar, not only for pulmonary hypertension providers, but more importantly, in many ways, for general clinicians, whether you're in an emergency department, whether you're a general practitioner, or whether you're a general pulmonary or cardiologist. Those things are really the front lines of detecting this and then getting people into the pathway. And if you want to be good, right, you have to not only know what the common things are, but when common things don't get better, refuse to anchor yourself and have a discerning mind about what else could be going on. And I think that's the key.
I think that's a great answer. Thank you so much, Dr. Chaisson. I think that really summarizes perfectly why we've decided to do this mini series on rare lung diseases, because exactly that, common things are common, but you can't discount that when it doesn't fit into the box, you have to think well outside the box sometimes.
Absolutely. It was a pleasure to talk to you today. Thanks so much for having me. I really enjoyed it. And I hope you guys have a wonderful
A
day.
pleasure to have you too. Thank you so much. And to our listeners, stay tuned for the next episode in our Rare Lung Disease series, where we'll continue unpacking the science and clinical strategies behind rare lung diseases. Until next time, stay safe, stay well, stay curious.